So in this section, we'll be talking about some treatments for seizures. Let's start off with some basic principles for medications for seizures. The first thing is deciding what type of seizures the patients are having. What sort of epilepsy is it? Is this a focal epilepsy or a generalized epilepsy? The importance for this is that some medications work better for generalized epilepsies and some work better for focal. This can be determined by the seizure type, just the description you give the neurologist for the seizure, or with the help of an EEG test. There's also broad spectrum medications which treat both focal seizures and generalized seizures. What I'll often do is I'll use a broad spectrum medication for seizures unless I get a very clear story for focal seizures along with an EEG consistent with focal seizures, because I find that a lot of the broad spectrum medications may work just as well for focal seizures as the more specific ones do. If there's a specific sort of epilepsy syndrome, we know some medications work better than others. For example, with absence seizures, that sort of generalized seizures, we would use something like ethosuximide, possibly lamotrigine or valproic acid. Those are the medicines that work best for that epilepsy type. We may also consider the interactions these medications have with other medications the child's on or other medical conditions. The possibility of having adverse effects. A side effect profile and deciding which medication we're going to use is often the determining factor when I'm talking to families in my office about medications. Some of the older medications, which may be more effective, families don't want to use because of the potential for serious side effects. We end up using some of the newer medications with fewer side effects. And finally, cost. Some of the older seizure medications like valproic acid and phenobarbital, very inexpensive medications compared to some of the newer medications, so cost can sometimes be an issue for some families. Once we start treatment with a seizure medication, we have pretty good success at getting seizure control. When it's studied with large groups of patients with multiple seizure types, our chance of getting seizure freedom with medication is about 2/3, with about half of the people that we start medications on having complete seizure freedom on the first medication we put them on. With different medications and medication combinations, it becomes less and less likely that we'll achieve control, but still an overall good control rate with medications of up to 2/3. Checking drug levels or labs on medications is something that comes up with families. Often might be a reason for deciding which sort of medication we're going to use. We use drug concentrations mostly for the older medications where there's a narrower sort of therapeutic window. It's a range that we'd like to have the medication at where we know where we know we have the best chance it's going to work. And if it's over that, it's likely to cause side effects and toxicity. This is less of an issue with newer medications. So for example, if a child is on, say, carbamazepine, ethosuximide, valproic acid, some of the older medications, checking blood levels will be more important. And even some of those medications that have side effects that might affect your blood or your liver, we might check for those things also. With the newer medications like lamotrigine and levetiracetam, those medications we're less likely to have to use concentrations to guide our treatment. We'll mostly just balance the side effects versus seizure control with the newer medications based on some general guidelines depending on a patient's weight. What happens when medications don't work? Or even when a medication is working for a while and then stops working? The first thing we have to consider is there some sort of progressive pathology? Is there something going on in a child's brain that's getting worse and worse, and that's why they're not responding to medications? We might also check levels at that point to wonder if the child's metabolizing the medicine too quickly or if the medication is not being administered by a caregiver. Oftentimes, if seizures come back, maybe the medication hasn't been given appropriately. We also may need to increase the dosage of the medication. There's dosing ranges, and if we're on the low end of the range and seizures are happening, an easy thing to do is just increase the dosage. And if seizures recur and we haven't started a medication, if you have 2 or more unprovoked seizures with or without a normal EEG, would be a very strong factor to consider starting medications. So when do we discontinue anti-seizure medications? This is something that often comes up on the first appointment when I'm starting a medication. Families want to know the plan. When are we going to come off the medication? The evidence in the medical literature and general practice among neurologists is going for a period of being seizure-free for 2 years. So what I'll often do is I'll see a family in the office about a month after starting medication for a checkup, maybe 3 or 4 months later, then every 6 months, till we get out to around 20, 24 months. I may repeat an EEG at that point. If the EEG is normal, I'll wean off the medication after talking about risks and benefits of coming off the medication, one of the risks being a possibility of seizure recurrence. If the EEG is abnormal, we might wait another year or 2 before weaning off of the medication. A lot of this has to do with risks versus benefits of the medication. For a person who's just learning to drive or who's just moving out of the house or going away to college, we may delay coming off the medications if the person's been very well controlled until there's a more appropriate time that'd be safer for them to wean off of the medications. Now there's a few lifestyle changes that may help with seizure control. One is assuring adequate sleep. One of the most common triggers for seizures is sleep deprivation. So this is where families will report, a child being seizure-free, and then when they're up late studying for finals, sleep-deprived, maybe on vacation, unfortunately, with sleep deprivation and interrupting sleep patterns, it makes a child more prone to seizures. Also, any sort of illness, especially an illness with a fever, makes a person more prone to seizures. Sometimes this can be a 1-2 punch of having a febrile illness, being sick, along with being up all night. So you're up sick, coughing, maybe vomiting, so you're sleep deprived, and you have an intercurrent illness, and you have a fever. Those things together make you more prone to seizures. And so trying to avoid triggers can be one way to prevent seizures from coming on. A couple of treatments, which I won't spend much time on, just for the sake of time in this presentation, are the vagal nerve stimulator. This is an implantable device that stimulates the vagal nerve, which can prevent seizures, was more popular several years back. I'll often defer this recommendation for patients who failed medications or maybe have some sort of reason why they can't take medications of having a lot of side effects. Another treatment option is the ketogenic diet. This is a very restrictive diet consisting mostly of fats and proteins. It's a very difficult diet to have typical children take, is usually better for children who have G-tubes just because the diet is very unpalatable. Usually reserved for children with severe epilepsies that haven't responded to medications. The last sort of non-medication treatment that I'll talk about is epilepsy surgery. Epilepsy surgery has made a lot of good advances in the past few years. It's one of the treatments that, for appropriately screened and selected patients, can be curative for their seizures. These are patients who have focal epilepsies where we know one specific part of the brain has abnormal electrical discharges that are causing the seizures. Maybe in the middle part or the inside of the temporal lobe, we might call mesial temporal sclerosis or hippocampal atrophy. If we find a part of the brain where there's abnormal discharges and that's producing the seizures, these patients may be good candidates for epilepsy surgery if they failed trials of different medications. Even if you have an identifiable lesion, most surgeons wouldn't want to do surgery if the epilepsy's been controlled on medications.